Good morning, everyone. We are so excited to host this panel discussion today around medical management of obesity. I do want to frame the question that we're discussing today, and it's specifically around medical management. We do think that bariatric surgery has a really important role to play in this. Um, but if we were to combine both the topics, we'll be here the whole day. So we're going to come back in pieces and target each topic separately. Once again, good morning. I am honored to be moderating today. I'm going to try and fill both Dr. McGinn and Dr. Greensweg's shoes. So I am channeling my inner Gary and my inner Tom today. I look different though. Okay, let's get started. It is my honor to have a couple of really stellar speakers for us to talk about. We have back by popular demand from last year's initial discussion around medical management of obesity in our patients. Dr. Layla Abushamat, she is an endocrinologist in the section of cardiovascular research at Baylor College of Medicine. Dr. Abushamat's clinical and research focus is in cardiometabolic disease, specifically metabolic syndrome, obesity, lipidology, and cardiovascular disease prevention. And we also have Dr. Mahmuda Tasneem. She's an internal medicine physician at Virginia Mason Franciscan Health. She specializes in primary care for adults with a special interest in cardiology. And she loves the investigative side of medicine, putting pieces of a patient's health story together like a puzzle and witnessing the direct results in the improvement of her patient's health. And she feels immensely grateful to be able to witness the grace that so many patients exhibit as they struggle to overcome their health challenges. True primary care spirit right there. We have Dr. Anila Chadha. She is a family medicine physician who has been with Dignity Health Medical Group in Bakersfield since 2014. She specializes in managing patients with obesity and helping patients reduce the burden of weight-related comorbidities like prediabetes, diabetes, hypertension, obstructive sleep apnea, PCOS, and degenerative arthritis of the hips and knees by treating patients in a weight-centric manner. She believes obesity is a chronic medical problem and should be treated comprehensively with diet, exercise, and anti-obesity medication and metabolic surgery if needed. We have two of our wonderful clinical pharmacists on the line, as well as leaders in their own rights. Dr. Tulay, she's an ambulatory care clinical pharmacist for the Greater Sacramento area and Bay Area at Dignity Health Medical Foundation. She holds a Doctor of Pharmacy from the University of Pacific Thomas Long School of Pharmacy. She started her role in 2016 after leaving pharmacy consulting, and she is currently a preceptor pharmacy resident for Mercy General, Mercy San Juan, and UCSF. And then we have last, but certainly not the least, Dr. Erin Sharp, back again by popular demand, serves as System Director, Retail Pharmacy Services, has worked in retail and specialty pharmacy space as a pharmacist and a leader for over 20 years. So quite the treat this morning. I am excited. We want to engage with you, so please use the chat function or the Q&A function, sorry, not chat, Q&A function to submit your questions, and we will be moderating as our speakers get started, okay? And I hand it off to you, Dr. Abushamat and Dr. Tasneem.
Thank you so much. I'm Mahmuda Tasneem, and thank you for the introduction, Ankita. That was very grand. Thank you. Next slide. So we're going to be talking today, review the CommonSpirit Medical Management of Obesity Guidelines as a resource for comprehensive approach to weight loss and management, discuss updates in medical weight loss, and identify ongoing barriers to medical management of obesity. So I'd like everybody's attention to these guidelines. The physician enterprise leadership, Dr. McGinn, Dr. Sagar, and Dr. Greensweg gathered a group of providers to create this document to help PCPs practice evidence-based medicine, especially regarding obesity. So this document actually reviews step-by-step approach to a patient for evaluating and treating obesity. I'd encourage everybody to take a look. This guidelines is about 18 pages long, but very user-friendly. Next slide, please. How do you access this guideline? This is a quick slide. So you just go into CommonSpirit website. Next slide. Physician enterprise. Next. Internal resources. Then the library. And then you find and you can actually favorite this for easy access. Yes, you just type in obesity and you'll be able to get that. There's also a link, and we can put the link on for you. Next slide. So in a nutshell, this guidelines goes over the algorithm of obesity. And I'd like to spend a few minutes on this. And like I said, it's just 5 steps. It's kind of relatively easy if you just look at it as a stepwise approach. So the first step in managing a patient who comes into the clinic is to figure out what their BMI is. And then once that is done, the next step is to look for comorbidities. Most of the patients that come to see us want help with their comorbidities, at least control or resolve it. So it's really important to figure out what the comorbidities are and focus on that. And then the third step is actually a really important step, because this is assessing the patient. How ready are they to change? And motivational interview plays a big role in obesity medicine, especially meeting them where they are and having them commit to change. So seeing the readiness for change, then the next important step is medication reconciliation. Really diving and looking at what medicines they are taking that could cause weight gain and seeing if we can find alternatives. The guidelines actually has a table, and it's a long table, and it clearly tells you what can cause the commonly used medications that we see in our clinic, and the alternatives. And if we can, we need to change that. The next thing is to look for comorbid conditions like sleep apnea, depression, anxiety, make sure those get treated. Look for eating disorders, especially binge eating disorders and night eating syndrome, and see if we can help with that. Last is to look for physical activity. Is there anything that limits them to be physically active? And then help them seek help, like physical therapy, guided exercises to get them out of that. Once the assessment is done, the next step is to look at labs. Now, you don't have to do the labs on every patient, but I'd like to focus on 2 labs that is important in obesity medicine. And one is in the reproductive age, young women reproductive age that want to get on medication, urine pregnancy test, and documentation that pregnancy and lactation is a contraindication for all of these medications. So initial visit, every follow-up visit, really emphasizing that is important, and documentation is important. The next important thing is FIB4 calculation, especially in patients with a BMI of 40 plus, or a diabetic with even class 1 obesity, monitor for fatty liver, and it should be done on a yearly basis if they still fall under that category. And then the last is the management. The management is 3 folds. One is the counseling part, and the counseling is divided into it's lifestyle management. It is talking about diet and exercise and really encouraging our patients to hone those skills. And then the second is medication management, and then surgical consultation when necessary. Next page, please. Next slide. And so I'd like to kind of talk a little about BMI. Getting an accurate BMI with an accurate height is really important because there are 3 things. One, BMI helps us categorize obesity. So is the patient overweight? Is the patient, which class of obesity do they fall under? That's one. The second thing is it helps determine who qualifies for pharmacotherapy. So it plays a very important role, and insurance companies are going to look at this. So documenting that clearly is the second step. The third step is it also helps us in, almost all hospitals are in value-based medicine. So it helps us code appropriately the HCC coding, and we'll talk about that in a little while. In general, if you look at BMI is broadly classified into two groups at this time, Asians and all others. So the difference between the two groups is about 2.5 points. So for instance, a BMI of 40 in the general population is considered class 3 obesity, but in an Asian is 37.5. That's kind of what is considered class 3 obesity. In the obesity clinic, BMI has its limitations. So using BMI and waist circumferences gives us a little better evaluating point. Next slide, please. So BMI, like I said, has its own limitations, right? The cutoff was for observational studies, mostly on white populations based on association of BMI to mortality. It's, like I said, it's not very accurate. So this slide really illustrates that. If you look at the incidence of type 2 diabetes, 10 out of 1,000 people per year in the white population have diabetes when they reach 30 BMI. And when you look at the South Asian population, it's at a BMI of 24. And then there are multiple ethnicities that come between them. So it's not an accurate, especially in different ethnicities. And keeping that in mind is a good idea. Unfortunately, ICD code is just for one general population. It's not even specific for the Asian population, even though it's recognized. But documenting that the patient is Asian and then you classifying them will make a difference. Next slide. So this is just a practical slide. This is about HCC coding. Both BMI and severe obesity diagnosis is needed for appropriate HCC assignment and risk contribution. Increasing a patient's risk score will help to adjust CMS monthly payment amount to be more reflective of the cost of the patient's care. For example, if a patient comes with a BMI of 40, both the ICD-10 codes, that is the E code, which talks about severe obesity, and the Z code should be assigned. If you only do one or the other, you do not get the RAF score. Similarly, for a patient, this is where the BMI becomes important. If you have a BMI of more than 35, but even one risk factor on the thing that I talked about, then you can assign the risk of severe obesity in this patient. So next slide. And this just kind of goes away. If you're non-specific and you choose non-specific obesity, the RAF score is 0. So if you do the E, if you choose severe obesity and then the specific BMI code for each patient, for the person, then you get a RAF score of 0.273. Thank you. Next slide. So then now to move on to the last slide and the management of obesity. Really, we as providers, we really need to talk to them about their lifestyle. This is the most important part, along with medication if they choose to go on it. So the components diet, they did a bit, study and they looked at 17 different diets. All diets help you lose weight. The key is adherence to the diet and calorie restriction. That is the key, and that is what we need to emphasize. Physical activity, the goal for all our patients is to get to 150 minutes of physical activity a week. And then we need to encourage them to monitor their food intake, calorie intake, physical activity, and weigh themselves on a regular basis. Next. What the best evidence for 5 to 10% weight loss is with face-to-face sessions with the healthcare system at least 1 to 2 times a month. And this has shown that it does help patients maintain weight loss. Next slide. So this is a quick slide on, again, just a practical slide on intensive behavioral therapy. And like I said, 1 time a month, 1 to 2 times a month meeting with a healthcare system actually helps our patient. And this is actually CMS. It was adopted in 2011. Qualified physicians and non-physician practitioners can participate. Maximum 22 visits are allowed in a month for our patients, but it's rarely used. Less than 1% beneficiaries use it. That's mostly because providers are poorly trained in nutrition and obesity, so we don't use this at all. Next slide. So what proof do we have that behavioral therapy really works? So this look ahead trial, if you look at the look ahead trial, it looked at 2 prongs, it's intensive lifestyle intervention and diabetic support and education. The 6,000 patients study was stopped after 9 years. because they were looking at cardiovascular outcomes, and unfortunately, there was no good outcomes. So, but what they noticed was A1C reduction, diabetes remission, neuropathy, nephropathy got better, quality of life got better, incontinence, sleep apnea got better. The one negative part of this, after 9 years, they found that the fragility fractures increased in these population. Next slide. So did weight. Weight improved, and it stayed good 10 years later, close to 9 years. With help and guidance, it did stay down. And so did the waist circumference, actually continued to stay down. Go ahead. So clearly, behavioral interventions do work with the help of the healthcare system. Holding them accountable makes a big role. And this slide is just to show how challenging weight loss is. Just advice alone doesn't do much. Exercise, just a blip. Then diet and exercise actually does help. And this was a study for 2 years, and it did show that. But the look ahead trial showed it for 9 years that it's sustainable. That is the end of my slides. I will have Dr. Layla Abushamat take over from here. Thank you so much.
Thanks, everyone. So to kind of go off of this slide, and again, weight loss maintenance is very challenging, and you can see that with most of our modalities, you see weight regain over time, despite initial weight loss. And one thing we want everyone to come away from this talk knowing and to stress is that obesity is a chronic disease. And while we do have different factors that go into what drives a person's weight, just like many other endocrine problems, it is actually all a feedback loop. And in energy intake and energy expenditure are involved, of course, but as an endocrinologist, I would be amiss if I didn't mention all of the hormones that are regulating this process and, again, setting this feedback loop. So it's regulated by changes in our hormone levels, particularly those that affect our satiety and appetite. And I mention that because our anti-obesity medications, where do they come in? We mentioned lifestyle and particularly intensive lifestyle therapies. Those are extremely important, and they're the foundation of any weight loss management plan and are important to mention at each step. But oftentimes you do need something more to affect these hormone levels, to affect this feedback loop. And our latest medications that are all the buzz are these GLP-1 receptor agonists. Probably one of the first that had the greatest buzz is semaglutide, 2.4 milligrams subcutaneously weekly for obesity. And this was studied in the STEP trials. And the reason why, it was something that was a huge splash whenever it did come out. Well, firstly, you can see here that 92% of people on therapy lost greater than 5% of our weight. And I always mention this 5% mark because 5% is what we consider clinically meaningful weight loss. Typically, it's 3 to 5%. And so if someone is able to meet that 3 to 5% meaningful weight loss by the 3-month mark, then that is considered a success when it comes to anti-obesity medications. With semaglutide, as with some of these other medications, we usually go in a stepwise approach, going from the lowest dose, in this case it's 0.25, and then increasing monthly until we reach the maximum dose of 2.4 milligrams weekly. And as you can see here, people over the course of the study lost over 15% of their weight on average. But I like to show this slide because this shows the extension phase where they were taken off treatment. And as with many of our other slides that we had shown earlier with different interventions, in the case of medications, when you come off the therapy, chronically, people will regain their weight. And here it shows that about over the course of a year, they regain about 2/3 of their weight back. So again, this goes back to stressing that obesity is a chronic disease. Just like we consider hypertension to be a chronic disease, you put patients on antihypertensive medications. This is the same thing. These are considered medications over life. And we know from STEP 5, which is another one of our STEP trials using semaglutide 2.4 milligrams sub-Q weekly, they followed patients for 2 years. And you can see as long as you maintain the medication over the course of time, that it maintains the weight loss. And what we mentioned earlier, weight loss maintenance is one of the hardest things to do. And I want to just draw everyone's attention here to the difference between semaglutide and placebo. Again, we look at this greater than or equal to 5% weight loss, or clinically significant weight loss, and 77% of those on semaglutide were able to maintain greater than or equal to 5% weight loss. That's at 5 times more than those who were on placebo. And so along with the fact that it is a chronic disease, we like to think of it now also as obesity-based chronic disease. And this is a term coined by some of the endocrine associations. And this is just recognizing that it's more than just about the amount of adiposity that one has, but also how it functions and the distribution of adipose tissue across the body. You can have different amounts of fat and different kinds of fat that lead to more sick fat versus just a fat mass disease. And, I bring this up because health at every body size is a movement, and there's a lot of stigma against weight and just discussing weight in general. And particularly in a lot of these patients, there's a lot of internalized weight bias as well. And we are shifting away from a BMI-centric approach to more of a complication-centric approach and focusing on obesity-related complications as well as an overall healthy lifestyle pattern. And when I say that, that means that we are looking to see, if we can have them lose weight, not necessarily just based on a certain number to reach a certain goal weight, but also to alleviate their complications that could lead to increased morbidity and mortality. And this is a new phase of a lot of our, trials that we've been doing. And so the SELECT trial particularly came out this year. And this was testing semaglutide 2.4 milligrams weekly in a cardiovascular outcomes trial, again, looking in a randomized double-blinded parallel group study, comparing the weekly semaglutide to placebo as an adjunct to the standard of care in the prevention of major adverse cardiovascular events. And they looked at this over the course of 5 years. They enrolled over 17,000 adults over the age of 45 from over 41 countries who had overweight, obesity, and cardiovascular disease and did not have diabetes. And you can see here for the primary endpoint, we see a 20% reduction in cardiovascular disease outcomes. So this was a positive study. So we know that those who are on this medication actually benefit from the standpoint of decreasing their future cardiovascular risk. And to continue on that theme, again, semaglutide was studied in patients with heart failure with preserved ejection fraction and obesity, which is many of our patients. It's heart failure with preserved ejection fraction affects so many of our aging population, so many of those with obesity, but also so many of those with diabetes. And here they assessed the impact of being on semaglutide on change in quality metrics with relation to heart failure, as well as how well patients improved their 6-minute walk distance and other markers of cardiovascular risk. And they found that semaglutide not only decreased symptoms and physical limitations, but increased exercise function along with that increase in weight loss. So these are just signs, and this is where we're the area is shifting more towards how we see these medications affect comorbidities, and the studies that we see coming out in the next few years will be highlighting that as well. We also now have dual hormone receptor agonists. Our first one to come out and be FDA approved is tirzepatide. It's a GLP-1 GIP receptor agonist. It's a single peptide with agonists to both receptors. And this was studied in the SURMOUNT trial. And here you can see that those on the maximum dose of tirzepatide had almost, on average, a 21% weight loss, very significantly increased compared to placebo. And again, we're looking here at our greater than or equal 5%, and 96% of people in this trial met that clinically significant amount of weight loss. And like I mentioned, it's now FDA approved for obesity as of November of 2023. And then it came out into the market as of last month in December. So this is our first dual receptor agonist that's been approved. But we have other agents on the horizon, and this phase 3 trial was released this year using oral semaglutide 50 milligrams daily. And we do have an oral semaglutide option for patients with diabetes, and it's at a much lower dose. They found that giving it at this high of a dose, you can achieve weight loss on average almost equivalent to that of the subcutaneous weekly. So again, this is an option potentially for our patients who are averse to using an injectable medication. And again, 85% of people on this therapy met clinically significant weight loss. I want to also just mention, I've been showing this, but I haven't really been mentioning, but over, around 34% actually lost more than 20% of their weight, which is a huge amount. And again, I'm saying it by percentages because we know that the amount of weight that you lose, the percentages, is related to the complication risk reduction that you can have. I mentioned that our first GLP-1 GIP dual receptor agonist was approved, FDA approved, and we have in our phase 2 trial and in a phase 3 trial ongoing right now, actually a triple receptor agonist. This is a GLP-1 GIP glucagon receptor agonist, retatrutide. These results were released also this summer, where they took over 300 adults with overweight and obesity and randomized them to either retatrutide at various starting and ending doses versus placebo. And you can see here, probably the most interesting part of this is that over the course of 48 weeks, and the other trials you had a longer duration of time, but over the course of 48 weeks, those on the 8 milligrams of retatrutide had over 24% weight loss on average. And again, 100% of them on the highest doses had over 5% weight loss. So this is a therapy that's upcoming. We have a phase 3 trial ongoing for that. And so we'll be looking to hear more about this as well. And this is something that potentially could be on the market in the next several years. The other one that's very promising is CagriSema, and this is cagrilintide, which is an amylin analog with semaglutide. And this is just a phase 2, but they currently have a phase 3 trial. They're calling it Redefine, and this is in overweight and obesity. This particular phase 2 trial was done in those with diabetes and overweight obesity. And again, CagriSema shows impressive kind of weight loss of about 15.6% on average. So these are some therapies that we have to look forward to in the near future. But again, we can't really have this discussion about all these exciting new therapies coming out on a yearly basis without talking about the barriers, including stigma, cost to patients and insurers, the medical personnel time required for prior authorizations and appeals, and the low supply and high demand that have led to a lot of kind of counterfeit or compounded therapies coming out recently. And so I just wanted to highlight some perceptions about anti-obesity medications. And this is a nationwide survey around factors influencing obesity care. I should mention it is sponsored by Eli Lilly, but they found that those patients with obesity identify it as a self-modifiable condition. And in that, they actually have a lot of self-blame. And about 64% of the participants were unaware of anti-obesity medications and that they're available and on the market. And they also, we see that with healthcare providers, a lot of healthcare providers view anti-obesity medications as short-term solutions. Again, this is going back to viewing obesity as an acute problem rather than a chronic disease. And providers hesitate to prescribe due to lack of safety or efficacy long-term and limited understanding of obesity. And, a lot of this, I hope, has improved over time. We have now data for over 5 years on some of the newer agents, but also we've been using GLP-1 agents in patients with diabetes since the early 2000s. And so now we're getting to around the 20-year mark and using medications with GLP-1. Some of our older anti-obesity medications, I'm not mentioning them here because they're not our newer agents, but some of our older ones have also had several long-term studies or even experience with long-term using them. And so a lot of these medications are safe if used in the correct patient. Lastly, employers see low demand due to low prescribing rates, but also low coding rates. We're not really coding for these patients and including these as codes when we are putting them into our encounters. And so oftentimes these are not included in benefit packages. while 51% of US adults actually meet eligibility criteria for semaglutide, and that's looking at it from 2015 to 2020 using NHANES data, there are many that cannot afford. And this is really just, this slide shows the different social determinants of health, and the different colors here are by race and ethnicity. And you can see here that regardless of race, ethnicity, and income, a lot of times those with lower income or lower kind of social economic status are the ones that probably need this medication the most, but do not have access and or cannot afford it. And I know those are all a lot of doom and gloom. And so I really wanted to end with kind of discussion of how, regardless of all of this negative, there is hope on the horizon and the future is bright. I mentioned so many different therapies that are up and coming over the next several years. So we will see increasing competition. Additionally, we have drug patent expirations coming up. For instance, liraglutide, which is one of our GLP-1, is actually the first GLP-1 receptor agonist that was approved for use in obesity at a high dose. It actually is going to be going generic this year. And so we'll be seeing that as a generic option, which would help reduce costs. We are hopefully going to be seeing effective oral therapies, so more therapies with the oral therapy that potentially could also drive down costs, as well as a lot of the cost is due to the method of injection, the pen itself, and the supplies. Potentially in the future, not only just combination therapy as using a single peptide, that can target multiple receptors, but also using our different anti-obesity medications together. There are studies that are ongoing for that. There are also studies to look at optimal frequency and dosing for maintenance, because I know a big concern is that this is, like I mentioned, a chronic disease. So we are using medications chronically. So this is a lifetime of cost, not just initial cost. And so how can we boost cost effectiveness? Is there an optimal way to do this? Can people take it potentially once a month and be able to maintain weight loss? And that data is to come. And lastly, pharmacogenomics, who responds best with the minimal side effects? For those of us who have used these medications, while we do have these studies, it's certainly very evident that there are some patients that respond better to certain anti-obesity medications and some that respond worse. And so, with each of these trials, we always present the average amount of weight lost, but with every single one of them, there is a waterfall plot that shows people who have lost varying amounts of weight, and we have a variable response to these medications, just like we do with lifestyle as well. And so a part of this could be pharmacogenomics. There could be a way in the future where we can identify what medication a patient would respond best to. And lastly, another little kind of potential light is there was this Treat and Reduce Obesity Act of 2021 introduced in the House and has been discussed, and is something that we have a lot of people who are, advocating for it. And so advocacy does work. So for all of you, all providers are advocates, but patients themselves have also advocated for this. And the reason I'm very excited about this is because it allows for coverage under Medicare's prescription drug benefit of drugs used for the treatment of obesity or for weight loss management for individuals who are overweight. So this would expand coverage to include medications for overweight and obesity. Again, this would allow Medicare really to acknowledge that obesity is a chronic disease and that these are chronic conditions that need medication therapy. And so in the future, we will see hopefully Medicare start covering more of these medications, but once Medicare covers, we'll see that also kind of extend to some commercial insurance companies as well. And so this is a very new and up and coming area. There are updates on a monthly basis. We could have an updates talk probably every month when it comes to this area. And so please continue to be on the lookout. It's very exciting and there are options, even though it does sometimes feel very hopeless and very difficult for our patients, but also as providers and trying to help our patients. And with that, that is the end of our talk. Thank you for listening and thank you for having us speak to you today.
Thank you so much, Dr. Tasneem and Dr. Abushamat. That was lovely. We're going to go to our panel and lots of chatter. Thank you so much for submitting your questions. We've got a couple that we want to answer live. But before we get to it, I just want to continue those threads and pull at them just a little bit, especially when it comes to patients who, in some of our communities, low resourced, right? Or they have significant social determinants of health Dr. Chadha, you and I have talked about this at quite some length. I want to invite you to share your thoughts around how do you think about it, especially when you're in a place like Bakersfield, very high prevalence of obesity. What are your insights and how do you manage this?
So, multiple studies have shown already that obesity is more prevalent in areas with lower socioeconomic status. And there are multiple reasons and multiple barriers at different levels. The first is that barrier at the level of physician and at the patient level, as Dr. Abushamat mentioned, that a lot of physicians still consider obesity as a problem of calorie in, calorie out. And that stigma towards the treatment of obesity has to gradually go away. For that, we have to emphasize more on during the medical school education about obesity treatment. Grand rounds done by CommonSpirit like these are extremely helpful for that. Now, at the level of patient, they have this internalized bias that, it's a moral failure or it's an easy way out to take medications for obesity. So more and more education towards this will always help. Then we have a problem with access to obesity specialists. Studies have shown that in rural areas, if somebody wants to seek help from a physician trained in obesity medicine, they have to travel 43 minutes versus an urban area, which is 9 minutes. Now, transportation is already a problem for them. So adding telehealth services might be helpful in this direction. Then there are studies that have shown that people in lower socioeconomic status have been, their environment is more and more obesogenic. The number of supermarkets versus the number of fast food joints, the fast food joints are much higher than the supermarkets, so they don't really have access to healthy food. So a lot of things need to be done at the community level, but providers in their own community have to identify what resources are available and what they can offer to their patients. Then, of course, we talked about barriers at the insurance level, but understanding the formulary in your area, what is available in your Medicaid and Medi-Cal population is extremely important. So sometimes as providers, we don't update ourselves with those formularies. So that will be extremely important. Of course, to remove these barriers, if providers can equip their exam rooms with healthy lifestyle handout notes, which are more conducive to their community, that will be an excellent way to overcome these barriers.
Wow, that's so many tips right there. I want to tug at another one that you mentioned. I think it was mentioned by Dr. Abushamat and Dr. Tasneem as well, which is around access. But when we think about access, what we think about sometimes separately, but it should be together, is food insecurity or even just under nutritious food, right? And Dr. Lay, I know you are quite the expert on when it comes to targeting of marketing materials, or how do you approach a community that has that increased ratio of fast foods, but really technically is a food desert because they don't have access to fresh food. I want to pull you into this conversation a little bit.
Yeah, it's really shocking, but the food and beverage industry disproportionately spends most of their advertising dollars on kid-directed advertisements. So you've seen those McDonald's meals with Disney on Ice. And so the way that we can combat that is in the office, because that is where we have the most access to tools. And Dr. Chadha mentioned coming up with handouts and making those available. I know when we have patients come in the office, oftentimes we ask them about alcohol intake and nicotine intake. And oftentimes we ask them about physical activity, and we don't necessarily follow up with that. And so there's a lot of research that shows that only about 5% of Americans spend their time doing the recommended 150 minutes of exercise per week. And I think partially that's because we don't spend enough time following up with that. And so hopefully in the future we can talk more with our patients about the advertisements that they're seeing, and allowing them to ask us questions about that. Because the more time we spend with that, the more they see that it's an important issue.
Absolutely. I think even broaching the subject is part of starting the conversation, might just be the key, and then following up, like you said, it's so important.
Yeah, absolutely. I think a lot of the conversation should be started because as Dr. I think Abushamat noticed, or I think it was Dr. Tasneem pointed out, there's a theory called set point theory. And so prevention of overweight and obesity really is the starting point for treating these two conditions that are chronic.
Right. Thanks, Dr. Lay. I want to come back a little bit to something that a lot of us are seeing on social media, and I appreciate Dr. Gray putting that question in the chat. Dr. Sharp, we've talked about this. What is this thing about compounding? Help us understand this. What is happening about compounding and meds and GLP-1s and GP-1s?
Yeah, so when GLP-1 started coming out for weight loss, they immediately went on back order. We used them for diabetes, and they went on back order and we couldn't even treat our diabetic population because of these drugs. And what happened was, in the world of pharmacy, when things go on back order, you're able to compound it. So these pharmacies took up and started compounding it. The challenge with these compounds is that they're not necessarily the same active ingredient. It is a salt version in most cases of the actual semaglutide or any of the ones that they're starting to compound. So there's really no proof what those patients are putting in their bodies is what they would have gotten in the traditional medication. The other challenge is the FDA does not control these or regulate these compounds. They don't test them. They don't have to send them for those tests. They're not patented products. So what is coming in those compounded vials is not necessarily what the patient is expecting. There's been a number of adverse reactions, not just injection site reactions, but different gastrointestinal problems, all kinds of different reactions that are coming. It is much, much cheaper to do it this way. If you actually just search compounded products, you're going to find a number of natural medicine telehealth providers that are offering compounded medications. It's basically online internet pharmacies. You can get them through the mail. You can go locally. I know I live here in Phoenix, and there is an absorbent amount of weight loss centers where you can walk in and get those compounded medications, but there's just no guarantee that what you're getting is truly what was intended for your body.
Right. So, it sort of murkies the water of, when we're thinking about efficacy of medication or the appropriate dosing of medication, we're not really sure what's happening. And it sounds like there's also this patient safety risk because we think about interactions a lot in all of our clinical sites. So what are they actually taking? Now, Dr. Abushamat, you had mentioned sort of there's been a professional society guideline or stance they've taken on this. Can you clue us in on that?
Yes, so the Obesity Society as well as the Obesity Medicine Association have put out a statement actually this month, given that January, a lot of people, their New Year's resolution is to lose weight and are looking closer at these medications, at these options, and see the compounding agents as potential affordable options compared to what's available. And they do have released a statement basically stating exactly what Dr. Sharp mentioned, is that these medications are not FDA regulated, and we don't know if what we're getting is what is stated. And there are unknown risks with using these medications. Even if for one patient it may be fine and there's no risk, some patients there've been history of medications that are compounded that have had serious side effects and serious risks. And so there's definitely a statement out there by our associations. The FDA has already put out a statement as well as of last year.
Great, thank you. I'm going to bring us back to a little bit more of the pharmacology and experience piece of it, because there's a couple of questions in the chat. What about non-GLP-1 drugs? Is it reasonable to start them before we go to GLP-1s? Also, share a little bit about experience with phentermine, right? Because I remember the 90s and the 80s, it was like the thing to do. And then all of a sudden, boom, no more. Nobody was on it. You guys share, maybe I'll go to Dr. Tasneem, Dr. Chadha, and Dr. Abushamat, and of course, Dr. Sharp and Dr. Layla chime in.
I can take that on. In the real world, the oral medicines are more affordable at this time. So especially phentermine and topiramate, the Casimir we can do from Medvantx for $99. So if you are worried for a patient that has anxiety and sleep, you can start low and then build up. But once you get them to 15 milligrams of phentermine and topiramate, you can actually switch it to the generic version, which drops their price by half. So phentermine in our state is about $15 per month, and topiramate is about $20 per month. Out of pocket, we're talking. Unfortunately, even this is not covered. The generic version also is not covered for most of our patients. So they all are paying out of pocket. But coming to your question about how effective it is, phentermine actually really is, phentermine topiramate is pretty effective. I mean, you get 10% body weight loss and 5% in about 70% of your patients in 6 months. And then what it's shown is long-term use of phentermine in about a year to 2, the weight loss maintenance is there, and they continue to lose weight with our help, holding them accountable. And like I said, the look ahead trial shows us clearly, if we keep pushing, if we emphasize behavioral changes has to happen. I almost sometimes feel like I'm not a Catholic, but I feel like I'm in the confessional box. Patients will open up and say, I did this thing wrong. And then I'm like, okay, let's go back and do all those things that you said wrong. Let's correct it. But phentermine helps. Contrave, coming back to the other medicine that we have, Contrave, the bupropion and naltrexone, that I think amongst all our drugs is probably the least effective. But again, you'd be surprised, like Dr. Abushamat said, some patients respond so beautifully to it and some don't. So the 2 drugs we have use it, and I hope that semaglutide 50 milligrams will come and hope that will open up. I hope I answered your question.
Thanks. Dr. Chadha, Dr. Abushamat, anything you guys want to add to Dr. Tasneem said?
Yeah, I can add something. So phentermine and topiramate are still excellent medications, and so in specific populations, in my experience, so if patient also has problem with alcoholism, then medication like Contrave, bupropion, and naltrexone works very well. In certain population, if evening sweet cravings, if that's a problem, then phentermine, topiramate, that combination works pretty well. So obesity treatment ultimately is like a precision therapy, individualized therapy, and these medications absolutely do have a role.
Yeah, I agree. And those were our medications for the longest time. Those are our only medications. And we all get very excited about GLP-1s, but like I mentioned earlier, there's such a variable response. There's some patients that actually respond better to phentermine topiramate than a GLP-1. So it just also depends on what is one of the kind of intrinsic factors that are leading to the weight gain for our patients. And all of these medications target different areas of our body and in sometimes multiple ways. And so not only centrally acting, but also peripherally acting. And so it also depends on the patient, their comorbidities, what are their motivators, and what are the kind of factors leading to their weight gain over time.
Yeah.
I'm sorry. Also, Dr. Abushamat had mentioned combination medications. So there's a role to see if we can combine small doses to get the best benefit.
I want to give Dr. Layla a chance to chime in. I see you wanting to chime in, and then I have a follow-up question for you, Dr. Layla.
Okay, yeah, in my practice, I see phentermine used past the 3-month recommended FDA period. I do find that even when we continue it long-term, people are able to maintain the weight loss. My only concern with phentermine when used long-term is because it's a sympathomimetic, it can increase the risk for insomnia, things like tachycardia. And so I think that's the reason why there's a timeline associated with it. So I think with any kind of medicine therapy, individualized approach is the best, which means that we have to chronically follow with these patients and ask them about their side effects.
Yeah, that reevaluation, right? Like we always tell people, ask them what their med list is. Has anything changed? And is it still effective? So agreed, 100%. Dr. Lay, this question is really from our previous conversation around supplements, right? Because we're also talking about non-GLP meds. What about supplements and taking supplements plus these meds? Any concerns?
Oh yeah, supplements are a lot cheaper than the GLP-1s, right? And they're also cheaper than phentermine and other options in general. So it's a tempting way to go. Unfortunately, I will say that the FDA has issued numerous warnings to consumers about traces of medicines that have been taken off the market. For example, sibutramine, that was taken off the market in 2010 because of the increased risk for heart-related issues. And so in 2016, we actually found that between 2004 and 2012, 237 dietary supplements were subject to a Class 1 recall by the FDA. And of those, 27% of them had weight loss dietary supplements that were not approved. So just like the conversation around compounded medicines earlier, we're not testing supplements on the shelves. And so in order to get the most efficacy and the most safety, it's best to use a prescribed medicine that your doctor or your provider is aware that you're taking.
Right. I know we're almost at the top of the hour, but there's two really quick questions that I wanted to ask. Both of them are from the chat also. Dr. Tasneem, you had mentioned cutoffs are different for patients with Asian ancestry. And we, meaning this group, has been sort of the brainchild behind our succinct guidelines. Can you briefly tell us why is there a difference for Asian ancestry versus non-Asian ancestry?
So I think that graph, that shows us the incidence of comorbidities seems to happen at an earlier cutoff point when we look at BMIs. That is the main crux. And just like Asians are more prone to osteoporosis, it's the structure, it's the genetic structure of Asians. They are smaller built, they're shorter. So BMIs, and I think also they were very involved, especially China and Japan were very involved in all these step studies. And they noticed that they were getting much earlier on, the comorbidities, and that's kind of why. But what we need to remember is BMI is not an accurate tool at all. That's what we have, and it's a cheap tool, so we're using it. It's really effective in Caucasians, but not effective in any other group. So, but when we look at other tools, it becomes very expensive. So to keep the cost down, BMI and waist circumference is what is being used at this time.
Dr. Abushamat, I know you had sort of mentioned the idea that it's BMI plus comorbidities, or really we're thinking about that healthy weight at any point concept is very different now than what it was before.
Yeah, and I think that's an important way to look at it. The health at every body size movement, I think we're not in odds with them. And really, it's just meeting the patient where they are. I really like how our guidelines stress kind of not only assessing readiness for change, but also assessing for other factors that may have impacted weight, including eating disorders, food insecurity. It really stresses emphasizing the individual patient. It's really hard for us to sit here and tell you this is what's best for all patients, because honestly, we are now so lucky to be in a time when we have so many different options, and so that we can tailor what we tell a patient and how we address their weight to the patient and to their prior experiences. That first visit is very important to understand where they're coming from and how they feel, the stigma and bias they have about themselves and about their weight versus what people in their community versus even ourselves. And I think that's important for all of us also as providers to kind of understand how our background, how our experiences, and how our thoughts about weight have influenced how we talk to patients about weight and about obesity. One of the things that our societies have stressed is using person-first language. So they're not overweight people or obese people. It is people with overweight or people with obesity. And so understanding that people are not their diseases, but that's just one small step. And it's important to kind of think about these from different ways. We get targeted by social media, we get targeted by our environment. And I do want to stress, I know we talk a lot about medication therapies, but ultimately the foundation is still lifestyle, and talking about lifestyle is important, and tailoring that based on your community and having overall healthy lifestyle patterns that are stressed. And it's not about perfection, it's about consistency.
Perfect. I think that is an ideal way of summing this up. Thank you so much. We definitely have to come back for round two. I can already imagine it, and lots more to discuss on advocacy. And I know that we touched on it today, but more to come. Thank you so much. This was great.